Good afternoon and top of the evening. Guess what time it is? 4 o'clock in the mountains, which means 6 o'clock on the East Coast. There is one place that you should be, and that is right here. It's Fertility with Fink and Friends. I am Fink. You are Friends, and it's great to see everybody here as always on this Tuesday evening. Live from Colorado Springs, Colorado, where I am the clinical director of IVF services here at CNY Fertility Colorado. It's been quite a week out there in the world, hasn't it? Between the weather and all the news headlines and everything else, it's just really good to kind of be able to sit down here with a bunch of friends and talk about all these things that are important to us. So a special hello going out to the first one joining here, and that was Forsaken Phoenix over there on the Facebook side. We've got some different feeds here. We've got Facebook. We've got YouTube and LinkedIn right here in the middle. We've got two different Instagram feeds. Here is CNY. Here is mine, and it's great to see everybody. Let's see who is here with us. My friend and colleague Brandis is here. Brandis Montez, our nurse practitioner at CNY Colorado. Hi to Allie. Gosh, we haven't seen you for a while. It's good to see you on board here. Special hello there to Amber Vince, of course, who is now about 32 weeks pregnant with her miracle baby. Hi to Sydney, who is from our wonderful embryology laboratory here. She is one of the great brains up there helping folks to bring their families into reality. Coco Fitness, good to see you. Chop and Guardians, I think that's what that says. Hi to you. Sorry if I massacred the name there. Over on the CNY side here, let's see, we have, looks like Simpleton 4610 was the first to join on CNY. Thank you for being here. Sohana Ali, Chewy and Oreo, I can't read it, it's too long, but something like that. Hey to Leah, Willow Chitty, nice to see you. Melissa Lynn, we've got Cutie Camp, and let's see, hi to Sam, Laura Lubahu, Dairy 16, Emily Wynn. Emily transferred a grade AA embryo yesterday. That is fantastic. Our fingers are all crossed for you, Emily. Cutie Camp is asking, can you do IVF if you have a dermoid? I'm a CNY patient and just found out I have one in one of my ovaries. So what is a dermoid? A dermoid is a particular type of a growth. It's what we would call a neoplasm, or a growth in one of the ovaries. It is the most common type of benign growth benign what we'll call neoplasm in the ovary. So it's a benign or non-cancerous type of tumor. So in fact, this dermoid cyst started, Cutie, when you were in utero yourself. It is a developmental cyst. It started to grow during your embryonic development. And actually what it is that it's a combination of multiple different types of cell lines that all sort of grow into this little growth inside the ovary. And as it gets bigger and as you mature, they have a tendency to want to grow and get bigger. And they actually, so surgically, they kind of get really gross. They're full of this like fatty stuff, this like liquid fat. They can have hair in them. They can have teeth in them, quite literally. That's one of the ways that you definitively will make that diagnosis, because you'll see that it's got teeth in it. So dermoids themselves are not dangerous to you. The concern that we have about dermoids, or really about any sort of cyst in the ovary, is when they get too large. When something gets to be above about 5 centimeters in the ovary, we get concerned that it runs the risk of twisting on itself, or what's called a torsion. Now, if you have a large dermoid in your ovary, we can usually, when we go to do an egg retrieval, we can usually work our way around it to get the eggs. But sometimes those dermoid cysts, they take up valuable real estate, as I like to say, that eggs will otherwise want to use to grow, to ultimately be retrieved. So it is not a contraindication to IVF to have a dermoid. It kind of just depends on how big it is. We don't like to rupture those things eggs inside of you because they can become very inflammatory to the lining of the abdomen. But so, yes, it is okay. You can still do it. Sexy Mary, hey, how are you? Does being overweight have any effect on donor embryo transfer? Well, so at CNY, we do not turn anyone away because of weight. However, we do know that if your BMI, your body mass index, is greater than 35, then your success rate with embryo transfers will be a little bit less than those whose BMI is below 35. So, and that's just the statistics. Those aren't CNY statistics. That's a kind of published data there. But there are many clinics who will turn people away, who will say, no, we will not treat you based upon some age limit or some limit with your AMH or some weight. CNY is not one of those places. So we are happy to take care of you no matter what. Simpleton 4610, my wife's testosterone is 0.39 based on baseline blood work. Well, so it kind of depends on the units that's in, but no, I don't think that that's a problem. In the units that I think of, I think that would be about a 39. That's the upper limits of normal, and that is okay. Let's say hi again to some of the folks here on this Instagram side. Ash Tenzueli. I just had my first unsuccessful FET trying a modified natural. Next, can you explain the protocol? I noticed that Omnitrope is on my medication list. So, well, first of all, I'll say that Omnitrope is human growth hormone, and growth hormone we know has potentially has the ability to help folks with egg quality. So I think of Omnitrope as an important thing to use for those who are having egg retrievals. I don't consider it as important, in my view, for people doing embryo transfers. Omnitrope is also an expensive medication. I personally feel like it's best used in other ways. So I typically do not include it as part of a medication protocol or an extra protocol for, or even an immune protocol, anything else for people doing an embryo transfer. So what happens with a modified natural transfer? So first, let's say what happens in a medicated cycle. In a medicated cycle, or a non-ovulatory cycle, as some like to call it, we are giving you all the hormone that you're going to need. And in fact, in so doing, we're shutting down your body's ability to manufacture that hormone. So we are really trying to control every variable in that medicated cycle. So 6 to 12 days of estrogen, that estrogen causes you to build up your lining. You get 6.5 days of progesterone injections, the progesterone in oil shot, followed by an embryo transfer. All right, that's a medicated cycle. In a modified natural cycle, or what we'll call an ovulatory cycle, rather than shutting down your body's ability to make those hormones and giving you all these hormones from the outside, we are letting your body take the lead in terms of those hormone levels. And so what does that mean? So you get 5 days of letrozole. So that's ovulation induction. Letrozole for 5 days will cause you to make sure that you're going to create a follicle in the ovary in which there's an egg. That follicle is lined with some cells. Those cells are called granulosa cells, and that's where we make our estrogen. So just like you do every month when you're not trying to get pregnant, you build up a lining in your uterus. That lining hangs out and waits for an embryo to come implant in it. But in this case, what's going to happen is that when we see that that follicle is of a mature size, we can trigger the ovulation, which tells the body to release the egg. And when it does that, you start making your own progesterone. So you just made all your own estrogen and you just made all of your own progesterone. So rather than having to get that big shot in your butt, you're making your own progesterone. So we give you a little bit of extra. We give you some vaginal progesterone to help with some local effect there. But in so doing, you're making your own estrogen, you're making your own progesterone, then you end up getting your embryo transfer. The levels that we expect with that are different than they would be with a medicated cycle. And the plus is that, well, you can continue to use the vaginal progesterone rather than the progesterone in oil. Now, the other advantage there is that some people, some studies, not some people, some studies show that we know that the natural cycle and the medicated cycle are at least equivalent. The medicated cycle has been around since they invented IVF. This is what they've been doing in the IVF world since, for 40 plus years. So there's a lot of data on it, and we are able to really control every variable. Well, so they're at least equivalent, but there's some studies that show that the modified natural cycle may be a little bit better, that there may be a little higher pregnancy rate, a little lower miscarriage rate, a little lower, and certainly there is a lower risk of certain types of pregnancy complications that happen a little further on down the line. So I am a fan of that modified natural and encourage you to do that, certainly if you can. Let's see what else we got going on in here. What can someone with DOR do to get pregnant with their own egg? So the diminished ovarian reserve doesn't necessarily reflect whether you can get pregnant with your own egg or not. So that's a question really of egg quality, and egg quality really isn't something that we can directly measure. Ovarian reserve tells me about the relative number of eggs that are still remaining in your ovaries. Now, they may go hand in hand, because let's say that you're 44 years old, you're going to have a diminished ovarian reserve based on age alone, and those eggs are going to be 44 years old. So the odds of getting pregnant with your own egg are certainly much lower. But what the diminished ovarian reserve tells us really more is how your body is going to respond to the medication. It's more the DOR question, or really the measurement with your AMH, your anti-Mullerian hormone, is more a question of what is your body going to do with the stimulation medications. And so when we decide what dosage to give you of medication, it's based principally on your age, and secondarily on what is your AMH. Now, some people will ask the question, and I think we've actually been asked this here before. Well, yeah, but I just had a tubal ligation. I had my tubes tied, and so I don't have fertility problems. My tubes don't work. So don't I need a lower dose, or won't I need less medicine? Won't this be an easier process for me because I'm not infertile? I just had my tubes tied. The answer is nope. It's the same thing, really, because it really has to do with how your ovaries are going to respond to the medication, and what is the quality of those eggs going to be. The sperm that comes out today was manufactured in his body 3 months ago. The eggs that are in your ovaries have been there since you were in utero. And right, so over that time, the DNA becomes less stable, and that's one of the reasons why it gets harder for us to get pregnant as we mature. So hopefully that answers that question. Let's jump back over towards the Facebook side. Looks like we got a bunch of people over there. And let's see, Allie Bright says, joining from Minnesota. Hello, got a positive beta yesterday from the transfer you did on 5/21. I love that. Would you recommend continuing or stopping CoQ10, fish oil, and vitamin D? So really, once you're pregnant, Allie, and boy, that is just fantastic. We are all so happy for you. Once you are pregnant, continue your prenatal, continue your fish oil. You really don't have to stay on the CoQ10. You really don't need to stay on the vitamin D anymore. Now, if your vitamin D was very low when you started on it, there may be a reason that you want to continue. But from a fertility standpoint, vitamin D is very helpful when it comes to implantation. And so sounds like you got that implantation. All the best. Oh, that makes me so happy. Love that. Jessica Huffman is here. Transfer 2 beautiful blast with you on Saturday, anxiously awaiting beta day. You know, I got to tell you, it is one of the hardest things is having to wait around, right? It's that time from transfer until period. And yeah, it's definitely a tough one. And speaking of which, the next Instagram post that I'm going to make, which will appear on both my Instagram, Randy Fink MD, and on CNY's Instagram, is going to be a little something about embryo transfer, because I've been getting a lot of questions about, kind of how does my embryo go into that little tube, and how does that end up getting me pregnant? Where do you place it on the inside? We've done videos before on, kind of behind the scenes at your embryo transfer, but this is specifically kind of about the embryo catheter. It's that piece that goes inside of you to make you pregnant, how we place it there, how the embryo goes in. And hopefully I'll finish that tonight. Maybe we'll be able to get that thing posted tomorrow. Forsaken Phoenix asks, when would you recommend a Zymote device? So Zymot, or Zymote, Z-Y-M-O-T, is a sperm preparation device. And basically what it does is that it allows, so under normal circumstances, our embryologist or andrologist, the folks in the lab, will sit down with a microscope and look at every one of the sperm that we have from your sample, and pick out the sperm that they believe is the best one in order to fertilize your egg with it, which is really, kind of amazing stuff when you think about it. What Zymo does, and I've heard some people, criticize and say, well, it's not doing anything that the embryologist or the andrologist, one of the lab people, can't do on their own. And that is absolutely true. But basically what it is that it is a little tunnel. Think about it as a little tunnel. All the sperm go in one end of the tunnel, and there's a little obstacle course on the inside. The best and the strongest swimmers get through the obstacle course first, and they come out the other side. And so those are the ones from which the technicians can sit down and look under the microscope and select the best sperm. So they're basically getting a better group of sperm from which to select each individual that they were going to do anyway. I think it's a pretty good idea, to be honest with you, in most cases. Is there any harm to it? No, as long as the sperm count is adequate. You have to have an adequate count. You have to have at least 2 million sperm, and there has to be adequate motility, meaning to say that the sperm are swimming. You like the visual that the sperm are, oh, here it goes right by the camera. I think that was a sperm. You have to have adequate count and adequate motility in order to be able to use the Zymote. It is about a $200, I think it's a $200 add-on in the lab. I believe it's probably worth it. Why? Especially in cases of what we'll call otherwise unexplained infertility, because maybe there is some male factor there that we weren't aware of, that we didn't know, and it really may be selecting out the sperm that have less DNA fragmentation, so less problems with the genetic material in that sperm. For a couple $100, I really do think it's worth it. There are some clinics that mark that Zymote up, that it's a couple $1,000s to use it, and I'd say that's ridiculous. But what they show in their data is that it improves, or rather it decreases, it decreases overall pregnancy rate by decreasing miscarriage rate. So it's decreasing miscarriages, and thus, because there will be fewer pregnancies, because the ones that are going to miscarry probably just will not create the embryo there, but in so doing, it improves the pregnancy outcomes, if that makes sense. So for a couple $100, yeah, I do think it's worth it, especially if you've had to deal with unexplained infertility or some other type of male factor. Tori Collins is here. I've been having a lot of bleeding. I had an ultrasound today, and my subchorionic hemorrhage has doubled in size. Think I'll be put on bed rest. I've been taking it easy and not lifting or walking around. Anything else I can do? So it sounds like Tori is pregnant, and Tori has what's known as a subchorionic bleed or a subchorionic hemorrhage. This is very common in pregnancy. It is even more common in IVF pregnancies. And basically, what happens is that as the pregnancy grabs a hold of the uterus, the uterus is going to grow. It's going to continue to move. And as that uterus moves, the placenta moves along with it and can shear off a little space underneath that results in a collection of blood. That collection of blood, or a hematoma, is literally a bruise under the placenta. 50% of normal pregnancies, 50%, one out of every two, will have some cramping and bleeding in the first trimester. All right, so it's a very common thing. It's hard not to be worried about it because you always think the worst. I don't think, Tori, that bed rest is helpful because bed rest, they've looked at bed rest does not improve pregnancy outcomes. In fact, it may make things worse. But I think you're doing the right stuff by not overexerting yourself, kind of taking it easy as best you can. Certainly keep yourself well hydrated. When subchorionic hemorrhages reach a certain size, I usually will stop, and most people will stop the blood thinners if we have you on a blood thinner. So that may be something also to look at. Fingers crossed there, Tori. It's a stressful time, but God willing, we'll have some happy news next week, right? Hopefully so. Liz Fisher is here. Always love watching your lives. Thank you very much. We'll be coming out in July for my first FET. Us ladies take so many supplements before, during, and after. Are there any supplements or meds that men can take to help with sperm quality? Yes, there is an evidence-based protocol for men. And in fact, I outlined that in my ebook, which is the Vitamin Victory, and that is available on my through my my Linktree page. It's linktr.ee, Linktree, linktr.ee/Randy Fink MD. Or if you can't remember that, then just on my Instagram, Randy Fink MD. It's the link that is in my bio. Click on that link. There is an ebook called The Vitamin Victory, and that goes through all of the evidence-based protocols for both for men, for women, for trying at home, for IVF, for diminished ovarian reserve, for you name it, embryo transfer. We've got it all right there. It also includes a link that gets you a discount on those supplements if you would like that. Ebook is $7 and you'll save yourself a bunch of money and hopefully a lot of hassle by doing the right thing from the get-go. But so you do raise a good point. Is there a sperm supplement that one should be using? Well, for men, there are there's about 8 or 10 different things, but they are all combined into one. So you can get one really good supplement that includes everything. No one has yet to make that for women. Women have to take the whole laundry list of things separately, whereas men can get it all together. They're not cheap, and it takes about 3 months for a sperm supplement to start to make a difference in what comes out and what they can see under the microscope. So, my opinion, for the cost of that, unless there's a real issue, if the semen analysis is normal, then I'd say, that the extra sperm supplement, I've yet to see any data that tells me that it really makes a huge difference if you already have a normal sperm supplement. I think the money may be better spent there on the Zymote, which is $200 to be used at the time of the sperm preparation in the laboratory. Good question there, Liz. Kelsey says, my CNY baby is almost 1 thanks to you, both retrieval and transfer. Oh, God, I love to hear that. Thank you. Hoping to transfer again soon. Is there anything I should be doing to prep? So if you've had a baby and you're planning on coming back to do another embryo transfer, we want to make sure that the uterine cavity is normal. So a saline sonogram or a hysteroscopy is a very useful thing to do so that we can make sure there's no polyps, that there's no fibroids or bands of muscle or scar tissue or anything kind of on the inside of the uterus that may prevent your beautiful, perfect embryo from trying to take up residence there on the inside. That's number one. Number two, there are a few supplements that are on the evidence-based protocol that I just mentioned. Prenatal vitamin, CoQ10, vitamin D, vitamin E, and L-arginine. And I just want to say this, we've said this before, L-arginine is something that confuses people. L-arginine, so all those other ones are things that you should be on for egg quality if you're doing a retrieval, except for L-arginine. L-arginine has been shown to not be as good for egg quality, so I don't recommend it. Evidence shows that you're probably better off without it for embryo creation, for egg retrieval. But it is an important thing for embryo transfer. And why is that? Because it increases the nitric oxide levels in the body, which increases the blood flow. It increases blood flow to the uterine lining and just makes that lining more hospitable to that beautiful little embryo. So those are the things. I would evaluate the uterine cavity and I would get on those supplements prior to embryo transfer. Aurora says those growths with hair and teeth. You can't convince me that it isn't an absorbed twin. I mean, come on. Well, I mean, I can see why you might say that, except that remember, these things are there from, they're there from birth. So, I guess what you're saying is maybe there was a twin from when you were in utero. Well, interesting. So, they know kind of the cellular origin of where they come from, but that is an interesting consideration. Could it be an absorbed twin? Okay, let's see what else we have. We've got, since I have, let's see, I'm not sure what you're asking there. I see a special lady has joined the show here, and that is a beautiful couple in Lower Alabama. A shout out, as in every Tuesday, to my wonderful mom and dad. Thank you for being here today. Victoria Lynn, what can cause recurrent water breaking placental abruption? This is my second one, no infection. I do have an incompetent cervix, but had my cerclage in and it still happened. All right, so Victoria, that is an unfortunate thing to have to deal with. Yeah, for sure. So let's talk a little about that. That's kind of on the obstetric side, and it's a little different than what we normally talk about here, but it's something that, God willing, everybody who's on with us today is going to be pregnant at some point, and so we should at least understand what that is. So the first thing you say is that you have an incompetent cervix. And what that means is that the cervix itself, the cervix is the opening to the uterus, and its job is to keep the baby on the inside. As you approach the time of labor, the cervix starts to do a couple different things. It starts to thin out and it starts to dilate so that the baby's head can present through the birth canal and thus be born. An incompetent cervix is one that, for whatever reason, is not able to hold the pregnancy inside. This usually presents as painless bleeding, usually in the second trimester, that may result in a severe preterm delivery. That is, the baby just kind of falls out. So how do we treat that? Well, it sounds like you got it. It's called a cervical cerclage. A cerclage is basically a stitch in the cervix that goes all the way around that we tie a knot in, and that holds the cervix closed so that if there's some mechanism in the tissue there that doesn't want to stay closed so that the baby's coming out, it's stitched closed so that doesn't happen. There are a couple of different types of cerclages. Usually those cerclages are removed at about 36 weeks of pregnancy so that you can have a natural normal labor. Um, Now, the other thing that can happen there, and Victoria, it sounds like this happened to you, is that your water broke, and that's kind of one of the risks when you have a cerclage. That if there's still some pressure on the uterus, it can cause the baby's bag of water to break, and if that breaks open, then you run the risk of bacteria making its way making its way up to the inside, resulting in an infection inside the uterine cavity. That usually is what's called that rupture of the membranes is what's called PPROM, premature preterm rupture of the membranes, PPROM. And that all itself can cause the placenta to separate and can cause you to lose the pregnancy. So that is truly a very frustrating thing to have in your history, because usually if you have it in your history, it's something that happened to you that no one was able to prevent. And so it is, leading up to a sad story. So I'm very sorry you've had to go through with that. So one of the leading theories is that there is some kind of low-grade infection on the inside that's causing the water to break, or that may be causing some sort of subtle preterm labor that's causing the water to break. There are some other thoughts that it may have to do with progesterone levels. And so, for the longest time, supplemental progesterone was used to treat folks who have that history of preterm labor. Um, Advice on what to do next. I think the best thing to do there is you have a conversation with the MFM doctor, the maternal fetal medicine, the perinatologist, the high risk OB doctor, because sometimes they are able to identify risk factors that may be able to be addressed and treated beforehand. Now, here's something else. It's kind of newer information. Even your MFM docs may not be fully aware of it. And we've talked a little bit about it here when we talk about recurrent implantation failure. And that's the folks who keep having embryo transfers. They should be getting pregnant, but they're not getting pregnant. Do you remember, as we've talked about this, we've talked about Prograf. Prograf, or tacrolimus, is the medication that, now that they've been able to elucidate probably one of the principal mechanisms that cause that recurrent implantation failure, how we can treat you in order to avoid it from happening. And I have seen, even in our own experience right here in Colorado, that it is making a difference in people's lives. People are getting pregnant who weren't getting pregnant before. People are staying pregnant who couldn't stay pregnant before. It's not a perfect system. They say it improves the odds to about 93%, which is great, but it's not 100. So that study further looked at, well, what about people who have recurrent poor pregnancy outcomes? And so they continued to treat them during pregnancy with this medication, 3 milligrams a day, divided into usually twice a day dosing. So 1.5 milligrams twice a day, or 1 milligram 3 times a day if you want to. And what they found was it lowered the risk of placental abruption. It lowered the risk of I think it lowered the risk of preterm delivery. It lowered the risk of premature rupture of the membranes. So that would be the one probably newest piece of information, something that may have just, within the last 60 days, potentially changed in terms of standards of care of obstetrics. Victoria Lynn, again, horrible that you had to go through that, but that would be my recommendation for you, that you would stay on Prograf until after that point in your pregnancy. And I think that may make a difference. And I'm happy to talk to anybody's maternal fetal medicine doctor, point them in the direction of that study so that they can read about it if they're not already familiar. It's not a current standard of care, so it may not be something that people are truly, really familiar with. Hey to Crystal, nice to see you today. Let's see, Llama, Single Mama, we haven't seen you around for a while. Welcome back. Should I have an existing hernia removed before another retrieval transfer in a pregnancy? It depends on what kind of hernia. So if it's a small umbilical hernia, like a belly button hernia, Probably not. And once you do get pregnant, you run the risk that that belly button hernia is going to kind of come back. Sometimes people talk about a ventral wall hernia where the muscles here, the rectus abdominis muscles separate, or maybe it's an inguinal hernia. So I think it depends on the type of hernia you have, how large it is, and how symptomatic you are with it. Special shout out to Jody Hoffman for being here today. Thank you, Jody. By the way, 35 minutes past the hour. We're here for another 25 minutes on Fertility with Fink and Friends. I am Fink, and you are friends, and we are here from Colorado Springs, living it up on a Tuesday afternoon. You know, this is what we do. It's my favorite time of the week, and it's so good to see all you guys. Siciliana Melissa says, how much HCG is used in a wash before an FET, and how long does it last in your system? Well, it's, for an HCG wash, it should not have an effect on a positive. It should not cause a false positive beta HCG. It is a topical effect. It would be the equivalent of taking some hand cream and putting it on your hands and then doing a blood test to see if you have hand cream levels in your system. You probably wouldn't because it's really not absorbed. So it's just a little bit, but it's a local effect, not a systemic effect, Melissa. So I would not expect to see HCG in your blood after an HCG intrauterine wash. What's the difference between a Neupogen wash versus an HCG wash? Can I speak to a nurse about changing my protocol from medicated to modified natural? Yeah, so if that sounds good to you and you'd like to do, if you're already in the cycle, this comes from VAABX. Not sure how I say that, but you get the idea. If you're already in your cycle, then it's probably too late to change it, because if you've already got medication for a medicated cycle, you can't really go from medicated to natural. You can go from natural to medicated if you need to, but if you haven't started yet and you're making plans for it, all you have to do is to kind of radio in, portal message in either to the global team or to the team that follows you in one of our locations if you're being monitored by one of the CNY facilities, and just tell them you don't want to do a medicated cycle, you'd rather do a modified natural, and that really should not be a problem. The difference between Neupogen and an HCG wash. I think of Neupogen more for folks who've had recurrent pregnancy loss, people who have chronic endometritis that we can't seem to clear. And it's also known to really help with thickening up the uterine lining, much the way intrauterine PRP does. Whereas an HCG wash, I think, is appropriate for everybody. HCG is the pregnancy hormone. It bathes that uterine lining with that pregnancy hormone, which improves some of the, increases secretion of some of the proteins associated with receiving a pregnancy. So that is the difference. Back over to the CNY side of the Instagram thing. Hi to all these nice folks who have joined. Thanks for being here. Looks like Prince's die, I think that says. How do you know if an egg releases from the ovaries after a trigger shot? Well, so it depends on what you're doing there, actually. So if you are doing IVF, for instance, and we give you a trigger shot, we don't want the egg to release from the ovary because we want to get it, right? We want to do that egg retrieval, and we want to retrieve those eggs. We want them to go to the lab so we can fertilize them. We don't want them to be released. But if you're doing an IUI, for instance, or you're doing home timed intercourse, we give you the trigger shot. It's the same mechanism that your body would use to cause you to release an egg. And what do you do with that? You release an egg. So most people don't have people who don't ovulate normally, it's usually not because there's a defect in the ovulatory mechanism such that we trigger you. Oh, well, then you're not going to ovulate. If you get a trigger shot, you're gonna release the egg. So there's a couple of stages in that whole process. So, like if we're doing IVF, well, if we don't want you to release the egg, then why are we even giving you a trigger shot? I always say, well, we're telling the ovaries we're coming for those eggs, baby. Get ready, because here we come. The egg is inside this little fluid-filled space. It's hanging out in there, and it's attached to a little stalk, right? It's like a dandelion. It's hanging on a little stalk there. And so when we give you the trigger shot, one of the first the things that happen inside the follicle is that the egg releases from the stalk and it starts free floating in that fluid. Now, in nature, what happens next is that the ovary functions like a squirt gun and it squeezes that egg out, and that's what ovulation is. In this case, we time it, and that's why the timing in IVF is so important from the trigger shot to the retrieval. It's 35 hours because we want to get there after the egg has been released from its stalk, after the body has told the egg to go through its final maturation process, but before the ovary squeezes that egg out. So how do you know it happens? Because it does. We can check, we can certainly check. A progesterone level will tell you if you've ovulated. Haley Adine says, medicated cycle this month. The left tube is confirmed blocked, but the scan this morning showed 2 follicles in the left ovary. Do I still have a chance? Yes. When you say medicated cycle, I guess what you mean there is that you're doing like a timed intercourse or a home intercourse cycle. So the answer is yeah. So if you have one tube that's blocked, your fertility is really not adversely affected. If you've got one functioning tube, it's pretty much just as good as 2. By the same token, if you've got one ovary, it's pretty much just the same as good as 2. You don't go into menopause any sooner. Pregnancy should still, be able to happen for you. And as you think about it, all these things, when we talk, you know what, I got to go back to my friend here, the uterus. All the illustrations and everything that we see of a uterus is that the fallopian tubes are on the side and the ovaries are sitting out here. Now, the ovaries are not actually attached to the fallopian tube. They're attached by a ligament that comes here and some blood supply that comes from here. But this is how it is shown, at least in the examples. And so it makes it look like this whole thing everything is localized one side or the other. But in fact, as this exists in the pelvis, as it sits down here like this, the ovaries and the tubes, they just sort of hang down in the cul-de-sac, kind of like sort of like that. So when one side releases an egg, it may very well get taken up by the other side. So to answer your question, even if you ovulate from the side that your blocked tube is on, yes, you absolutely still have a chance of getting pregnant. So fingers crossed. How about that? Hi to Rosa. I was put on estrogen and progesterone to delay a cycle until cycle day 11, but now I have a lead follicle at 13 millimeters despite being on estrogen and progesterone. The others are at 8, 5, and 6 millimeters. Should I still continue with this cycle? So I think that you are talking about for an egg retrieval, you're on estrogen and progesterone, but it sounds like that you had a follicle that grew anyway. And that's a challenging situation because they're not supposed to. It sounds like you didn't read your ovary, the rule book, Rosa. Geez, you could have had a little talk with her about that. It's not uncommon that we will need to do some logistics with people's cycles. And that is to use a little estrogen and some progesterone. It actually has some benefit on the ovaries and on the pituitary gland in order to be able to help to synchronize the growth of follicles. And so we can hold things off, and then you stop your estrogen and progesterone and begin your stim. So even though you said your cycle day 11, you stop your estrogen and progesterone, and then it believes that you are at the beginning. You're not actually cycle day 11. You'll be stim day 1, or what your body will think is cycle day 1, because it should have been getting held off there. So the first question I would have would be whether that 13 millimeter follicle was it there before? So maybe that was a little anovulatory cyst, an anovulatory follicle that was hanging out from before. If it wasn't there before, I would still say 13 is right on the cusp. If it were 14, I'd say, well, I would rather you aspirate that follicle. I'd rather, suck the juice out of it, because it can take up some valuable real estate again to keep the other eggs from growing. But at 13, I would say that you can go ahead with your cycle. I think that you will be safe in that regard. Let's see. What is Neupogen used for? I have implantation failure. I'll try the tacrolimus again. I suppressed my endometriosis with Orilissa for 2 months, and a euploid FET failed. Well, it can happen because that euploid embryo, 65% probability of pregnancy. It's not 100%. So even though you've done all the right things, which is to say, you've got a euploid embryo, you tested your embryo, you know that chromosomally it's normal. This is going out to Ash, by the way. You know it's a chromosomally normal embryo. You're on the tacrolimus, right? So that's a good thing. You suppressed your endometriosis with the Orilissa, so you've done what you're supposed to do there. What is Neupogen for? Neupogen raises up your white blood cell count. So it's another mechanism by which to invoke your immune system against things that shouldn't be happening, and to use your immune system for things to happen that aren't. So increasing your white blood cell count sort of stokes the fire on your immune system. And I would say, depending on what that history is, Ash, there's no harm in using it. It is part of our immune protocol, our level 3 immune protocol, so very commonly used. And I think you can feel good about that. But my guess is that if you've done everything else right, you did the Orilissa, you're on the Prograf medication, you've got a euploid embryo. My guess is your next cycle, you are probably going to be pregnant. I hope you've got some more euploid embryos, because I know that this is a tough process. Erica asked, do Midway lab results have an indication if transfer was successful? Either increase, decrease in progesterone or estrogen. So the estrogen level doesn't matter, but the progesterone level does. So really the purpose of the Midway labs after an embryo transfer is truly just to make sure that your progesterone level is adequate. In a medicated cycle, we are looking for that number to be above a 20. In a natural cycle, we're looking for that number to be above a 10. So that's really the purpose of the Midway labs. Progesterone is kind of the most important hormone as far as ongoing pregnancy, as far as things that we can manipulate and things that we can check. So that's really the reason for it. And hopefully that helps. Is there any benefit to luteal phase stimulation with a low AMH? Luteal phase stimulation is another way of starting a stim cycle. It's basically starting it kind of in the middle of the cycle instead of at the beginning of the cycle. The body is said to have 2 waves of follicular recruitment, one in the beginning and one in the middle. So it's just kind of another tool that we have. In general, that luteal phase stimulation doesn't give us the same number of eggs as we would get if we started in the beginning. So it's not something that I will typically resort to with great frequency. Should I also have a defect on my C-section scar removed before a transfer? Well, I think it depends on what kind of defect you're talking about. So sometimes the scar tissue after a C-section can actually block the cervix. So when we're making an incision in the uterus for a C-section, that incision is actually in the cervix. It's called the lower uterine segment, but that's really the upper portion of the cervix itself. And so that can sometimes change the anatomy. That can sometimes cause some scar tissue and make it difficult to be able to access the uterine cavity. Now, some people have a defect, like there is sort of a window, that there's a layer of great thinning there. And I would say if that's the case, then you probably do want to have that repaired, not so much before another transfer, but before another pregnancy, because that can have an impact on the future pregnancy. JM Dots is here. Good afternoon. Nice to see you. I am 46, confirmed mild endometriosis via laparoscopy last summer. For the FET number 5, we did Orilissa for 2 months with the aim of a modified natural afterwards. My body seemed to have completely shut down. High FSH and LH, any ideas? So the suppression does not induce menopause. And that's kind of what you're suggesting there, that, I think what happens is that the Orilissa, the medication for endometriosis, does suppress your hormones. And it can sometimes take a little bit of time to kind of come out of that. My recommendation there, JM, would be, so you know what, don't worry about doing the modified natural. Just go right into a medicated cycle. And that's usually what I recommend to folks. If they're trying to do a modified natural coming out of suppression and it's not working, don't keep, trying to throw this at it and that at it to try to get the body to respond. Just convert over to estrogen, progesterone. We can control all that and just get you pregnant, for crying out loud. Go with ride the wave of the suppression that you did there, and just move forward. So you can absolutely do, even if you were fully menopausal, let's say that you were 60 years old and fully in menopause, we can still get you pregnant. Not sure why you want to be 62 and have a kid in the terrible twos, but you can do it. Not with your own egg, obviously, at that point, but the uterus does not age the same way that the ovaries do. So we really can make just about anybody pregnant by giving them enough estrogen and progesterone. So even if there's some question about what is your pituitary gland doing, still kind of being a little sluggish to start after your suppression for endometriosis, just go ahead into a medicated cycle. Get the estrogen, get the progesterone, and for crying out loud, get pregnant, All right. I had a consult with you this past Friday. Oh, hello. And I forgot to ask if, since I have HS, will I also be doing the autoimmune protocol, LDN, and Prograf? So pretty much everybody at CNY gets some form of autoimmune protocol. We really do believe that the immune system does stand in the way of a lot of people getting pregnant. And, different people have different opinions on these things. Some people feel like, well, I don't want to take all that medication. And other people feel like, wow, that's the greatest thing. My other clinic totally, blew that off. So everyone will get some immune protocol. Yes, absolutely. Let's skip back over to our friends over here on the Facebook side. How are FET? This comes from Rachel. Hi, Rachel. How are FET protocols chosen? I've never talked about this during my consult. I have 2 day 3 embryos, and I've been told I'm doing immune protocol 1. Interesting. So when you talk about FET protocols, I presume you mean medicated or modified natural or natural cycle. The default is always going to be a medicated cycle, because again, this is what they've been doing in IVF for 40 years. It was, even maybe 2-3 years ago, we rarely talked anything about a natural or a modified natural cycle. It just was not something that was offered. 80% of the cycles in the United States are medicated cycles. So the default is going to be a medicated cycle. If you want something different, well, you can just ask for it. Surprises me to say immune protocol 1 for an FET, because most commonly we usually if you have a frozen embryo, if you've gone through IVF, we will usually do a level 2 protocol, but sometimes it may be level 1. Just kind of depends on the scenario. But even that is just a few things, just to kind of try to keep the immune system in check and to get it working for you instead of working against you. Let's see. Yep. Liz says there, he said in a previous live that everyone does a medicated cycle unless you ask to do a different one. If you consult with one of us, if you talk to me, they'll say, and you say, what kind of cycle do you think I should do? I'll say, well, you know what? I like the modified natural. It just, it's easier on your body, and your butt will thank you for it because you don't have to get the damn PIO shot, Let's see. Keisha says, what is the ideal levels for estrogen and progesterone on transfer day? Natural, modified with letrozole. So the first thing you have to know is that the estrogen level doesn't matter. The estrogen level will be artificially lowered because that's how letrozole works for ovulation induction. It lowers your estrogen, so you make more FSH so that you produce an egg. The progesterone, I am blanking on what we look at those progesterone numbers to be. So get back to me on that because my brain is skipping out at this moment. My apologies. Brianna says, is IVF worth trying when you only make one dominant follicle every month? So in fact, that's what everybody does. You have, so at the beginning of your menstrual cycle, you got a whole bunch of little follicles there that are all kind of competing with each other to figure out which one is going to emerge as the dominant follicle. And that's the one that goes on to be ovulated. So in IVF, we are giving you medication, stimulation, so that you create as many dominant follicles as we can get you to make. So a dominant follicle is normally one follicle in a natural cycle. But in IVF, the whole point is controlled ovarian hyperstimulation in order to get you to make as many dominant follicles as we can. Good question there, Brianna. Alex says, does high dose THC edibles affect egg quality, and would that be a reason for low quality embryos? There are cannabinoid receptors in really just about every part of the body. And so there's been some talk that CBD is helpful. I have not seen any evidence that says that THC edibles has an adverse effect on egg quality. Now, it can affect some other things. It can have a ripple effect in terms of your natural hormone levels and how you ovulate. So it can affect ovulatory function. And I have read some things that beyond some certain point, it can have an effect on implantation. But again, there are cannabinoid receptors in in the endometrium, just like there are in the ovary. So, pardon me. So, I don't believe that there is a problem there. Now, in general, we tell people, well, maybe you want to, steer clear of marijuana. You want to steer clear of alcohol. You want to kind of keep as clean a life as you can as you're leading up to your retreat. We'll see what happens when my brain gets fried at this time. Excuse me 1 second. Yeah, so we generally try to tell you clean up your act if you can, but no, I don't think it is a reason. I've not seen data that says it causes low quality embryos. Colleen's with us today. I'm confused on myo-inositol versus DHEA supplements. I was recommended the first, myo-inositol in the ovarian bloom, because I've been diagnosed with polycystic ovaries. But then my testosterone DHEAS came back on the low end in my blood work. My insulin was also low, so I stopped the inositol and started taking a low dose of DHEA. Expand a little more on what you do and if there's ever a scenario like, so myo-inositol is still going to help you. So make sure it's inositol or myo-inositol. Ovarian bloom is a fantastic supplement. I love it. And so I would stay on it because even though you may not need it in the same way. So medication that we use in that scenario is metformin, and so I think about metformin for folks who have an AMH level that's above 3 or less than 1. So it really does help with egg quality in both scenarios. So I think inositol is okay for you. Now, for those with a low ovarian reserve, that is the less than 1, the AMH of less than 1, DHEA is helpful. It's probably one of the two most important things that we can take along with CoQ10 to help improve egg quality. And that is irrespective of what your underlying DHEAS level is. So even if you don't check it, you can still use DHEAS. Colleen, I think that the key for you here is what is the AMH? If it's less than 1, I think the DHEA is a good plan. Either way, inositol is helpful. If the AMH is high, inositol is still helpful. But with a high AMH, I would not recommend that you use DHEA irrespective of your levels. Okay, so hopefully that's helpful. I could probably give you a whole lecture on that, but people would get very bored. And oh my gosh, look what time it is. It's top of the hour. Let's see if I can throw one more in here. I had an HSG. This comes from K Brown and was told that my tubes were clear. Could they have been blocked but cleared by the dye? Yeah, absolutely. That happens sometimes. And that's one of the reasons that people have an increased tendency to get pregnant after doing the HSG. There's an increased chance in pregnancy in the 2 months after doing the test. So it's not only diagnostic, it's therapeutic as well. Boy, the time crept up on me there at the top of the hour. I love being here with you guys, and I really appreciate you sticking around and throwing your questions in here. It's great to see patients in the office who say that they have seen my lives here and that their lives have been touched one way or the other by either the Instagram posts or by the questions that we try to answer. So I really appreciate that feedback and really truly appreciate you being here, because as I like to say, the whole infertility thing is not the book of your life. It is just a chapter, and like the sign says behind me from my friend Jody, this is not your novel. This is it's only a chapter, and what we're doing is to rewrite it every day forward with kindness, every day forward with love and hope for tomorrow, because tomorrow is a new day. The sun rises and brings all kinds of new things to all of us. I'll sure look forward to seeing you next week. Until then, thanks so much for being here, and good night.